We're going to talk about non-muscle invasive bladder cancer. I'll touch on a few things. I think Dr. Gonzago gave an excellent talk yesterday and kind of bounce off some of the things that he talked about. I'm going to go through several cases, and you can kind of in your head, think about what answer we think would be appropriate. I won't read the question. You can read it faster than I can talk. This is really a question about intervention and surveillance in a low-risk patient. So how do you survey them, or would you treat them with BCG or repeat the TURBT? This is a lady who had a TA high-grade tumor, say a 2-centimeter tumor, got BCG, it came back, 2-centimeter TA tumor. What would you do? So failed one course of BCG. See the options here. Micropapillary tumor, T1 at the dome in this patient. Here are your options. So I'm going to come back to those three questions and try to answer them later, and it's going to try to highlight some of the things I want as really take-homes. I'm going to talk a little bit about the AUA guidelines. As I mentioned late yesterday, I gave a shameless plug for the AUA guidelines versus any other guidelines because of the blood, sweat, and tears, and review my own thoughts and approaches along the way to this. So statistics, we know this. Majority, the numbers are there, over 500,000 survivors. And remember, the majority are low grade, 70 or 80%. Is a disease of older individuals. You really see the curve there. And I think as we have an aging population, these older patients, it's only going to be more that we see. So we have to be prepared to intervene and think about, again, long-term or chronic intervention. This is what I'm going to talk about, right? Non-muscle invasive. We've moved away from the term superficial bladder cancer to non-muscle invasive bladder cancer. I want to take a pause and talk a little bit about grading. We often now term it urothelial carcinoma and not TCC, right? So the kind of on the current terminology is UC. What we often use is this WHO 1972, right? Grade 1, 2, and 3. But there is the 2004 that's grade 1 and 2. How many people in their pathology report from the pathologist get a grade 1, 2, or 3 for the urothelium? There's a couple. How many get a low grade, high grade only? I'm so happy to see this because I would give this talk a couple years ago and it was still a grade 1, 2, and 3. And I often see the outside pathology reports with grade 1, 2, and 3. The problem with grade 1, 2, and 3 is the majority, if you have a grade 1, 2, and 3, so we know what grade 1 is, right? Low grade. We know what grade 3 is, high grade from an intervention standpoint. But when you look at the grade 1, 2, and 3, 70% of cancers are graded as grade 2. So they don't use the 1 and 3. And the problem with grade 2 is it's a bit of a garbage pail diagnosis because when people have reevaluated grade 2, half of them are grade 3, half of them are grade 1, right? So it's a cop-out for the pathologist. I think we really need to say, if they are doing this, tell me is it low grade or high grade, follow the WHO guidelines to that. We talked about these majority or non-invasive, majority are TA. This is 5% CIS. This is pure CIS. So we're often going to see CIS with TA and so forth. We know it's a disease that will recur, particularly concerned about progression, right? Recurrence we can handle, but progression. And we need to evaluate these patients for risk of recurrence and progression. I think that's when you develop guidelines, really have to be thinking about risk of recurrence and progression as far as risk stratification. The progress we made over sort of a decade is this was the guideline panels ran by Craig Hall. And then the most recent panel member is Dr. Rich, who's Dr. Gonzago's partner down in Miami. But I want to point out Diane Qualley. Diane is the founder of Beacon, where her husband died of bladder cancer. She founded Beacon. So we had a patient advocate on the guidelines, which I think was very important, right? It didn't talk about what the size of the tumor is and what you do, but how are they going to take this? So I thought that was a real important kind of input to what our guidelines were. I won't go through sort of the methodology. We use AHRQ, which is the Agency of Health Related Quality. A lot of papers boiled down to what I'm going to show you. Approved by the board, funded by the AUA. Panel received no remuneration for the work. Again, I keep bringing up that point. Yes, that's right. Unlike NCC, yes. So a couple of things in the guidelines, and we had the flexibility in these like the original guidelines, we could only say what was evidence-based, just that methodology of what the AUA wanted to do. And there's not evidence to, should we do a cysto and a TURBT, right? These are clinical principles. We see a tumor, right? There wasn't a trial that said, okay, do a TUR, should we do one or not do one? And you should do upper tract imaging. So cysto, TURBT, no-brainers. I always think TURBT, like we're advertising TURBT now, this minimal invasive, we use all the buzzwords of this, focal therapy, minimally invasive, targeted. I mean, our trainees, right, they want to jump on the robot and do all these fancy things, but they really, and I'll talk about this, they really need to learn how to do what's far more important for a bladder cancer operation is a good TURBT. Talk a little bit about some of the technology. The high definition imaging really has changed things significantly. We went through monopolar and bipolar. I mean, I kind of dragged Dr. Gonzaga through the mud a little bit yesterday. I mean, well, I think we agreed to the point that do whatever you feel comfortable with. And something I haven't taken into account with that was brought up by Mark and some of the crowd is, what is your team in the OR comfortable with? What instruments can you get? But I don't think it matters in either way. This is what I was talking about, a good TURBT. This is an interesting study. Younger surgeons compared to experienced surgeons, 7-fold higher chance of leaving residual tumor. 8.5 chance of not having muscle in the specimen. And these all have implications, obviously, from a cancer control standpoint. So a good TURBT is way more important for a trainee to learn than all these robotics and so forth that are kind of nice and fancy, but I think all of us who do this are on the front lines, right? And it's not an easy operation to do a good TURBT correctly. So this just says if you have positive cytology and a negative evaluation, bottom line, you can use, better new imaging, blue light cystoscopy and so forth, which we do use, but prostatic urethral biopsy. Why? Difficult to diagnose and treat, and it's dangerous. So 40% will have involvement. It is an important predictor of invasive disease. We can forget about it, can sit in the prostatic urethra, and again, be a harbinger of invasive disease. I will do, the way I'd evaluate it is I'll do a TUR at 5 and 7 o'clock near the VIR, kind of in those little corners. This has the highest concentration of prostatic ducts. This is where CIS can hide. And at a full thickness kind of grab of that, you can see if there's invasive or stromal disease in that. Next is the evaluation of risk stratification. So I've often in the past used these EORTC or the Spanish Cooperative Group Queto calculators. The EORTC uses, again, grade 1, 2, and 3, which is limiting. They don't incorporate re-TUR or prior BCG and the things that we do now. So this is the one that's online with the EORTC. You can even have an app, and that's what I would do to be able to tell a patient this is your risk of recurrence or progression. One of the other problems in this is you can see that the C index, which is the predictability, is close to 0.5, which is not far from a coin flip. So what we tried to do in these AUA guidelines and spent a lot of time is putting patients in buckets that have the same outcomes and the same treatment paradigms. And again, this intermediate risk, and what Mark talked about, that this one, the TA high grade less than 3 centimeters, I can tell you was debated with people thinking it's high grade risk and people think it's intermediate. And Mark, I didn't know about your guys' study basically validating the decision that was made, which didn't have the evidence that, yes, thank you for supporting that decision. But I think it can go both ways, but I want to highlight this. So intermediate risk, I do think these are two different patients. The low grades to me are risk of recurrence. And I think this high-grade TA is a little, I think of it a little bit differently. I think that's a risk of progression. I'll talk about that in treatment. I think the low-grade T1 is kind of a zebra, you know. We really don't see it very often. I want to talk a moment about variant histologies. You can read up here all of the concerning factors of variant histologies, micropapillary, neuroendocrine, and how they can be dangerous from a standpoint of many of them, majority will have T3, T4 disease at cystectomy. Pathologists really should report lymphovascular invasion and a variant histology. Because if you have T1 in a variant histology, that's a high-risk patient. So we recommended that if your pathologist is kind of wavering on that, just ask them to send it out and have somebody take a look at it. If you have variant histology, really the bottom line is they should have a cystectomy. A T1 variant histology should have a cystectomy. If there's some reason you're going to think about bladder preservation, re-TUR them and make sure that they're not worse than you think they are. A couple quick comments about markers. All have same limitations, either in sensitivity or specificity, cytology, limited sensitivity, but it's very specific. The bottom line of these is no study, again, you can read here, has evaluated the effectiveness, and these were kind of the conclusions given the uncertainty of biomarkers. You should not use them in place of surveillance and cystoscopy, right? That was always going to be the holy grail. Can we have something, a guy pees in a cup and we don't need to do a cysto? And the answer is no, you can't do that. In a patient with low-risk disease, normal cysto, you don't need biomarkers to follow these patients. You don't need cytology to follow them. Maybe you can use FISH to try to predict BCG response. I've taken out slides showing the data. I don't know. I don't routinely do that. People have shown maybe some effect to that. I don't like routine and reflexive use of FISH. Does that happen to anybody? You get something, and I've seen it from the gynecologist or in the community, they'll do a urinalysis and a reflex FISH. Have they gotten rid of that? Great, thank you. That was going to bankrupt our healthcare system. So here, again, a few other things on TURBT. You need to do a complete resection if you haven't done so. The bottom one is from the prior resection. You have a T1 tumor. You should go re-resect that tumor. I'll talk about why. Now it says if you have a high-risk, high-grade TA tumor, you should do a re-resection. So this is a little bit new now, right? This isn't just T1, it's TA high-grade, high-risk. Why we resect T1 disease? Just a study by Mike Cookson from a number of years ago. If you don't have muscle present, so these are patients they took to cystectomy, they will, about a quarter or more, even if you think you visually took everything out, will have residual disease. Even a great endoscopist will have that. And he showed that if you don't have muscle in the specimen, over 60% of those patients will have invasive disease. Even if you have muscle in the specimen and it's clean, over 30% of those will have muscle invasive disease. It actually, if you repeat the TURBT, your risk of recurrence and progression is better. So it's a therapeutic maneuver as well to try to get out the gross disease. Can you, I'll show you this is a study by Dr. Herr. Can you actually, does this give you predictive value? And this is where I think is one of the most useful findings, because what you find on your re-resection is very predictive. So if the patient has nothing, scar, their chance that they will have a durable response with BCG is almost 90%. So you can tell that patient, look, I resected you, it's high risk, I re-resected you, let's do BCG at 90% chance it works. If they have some non-invasive TA, CIS, still BCG is going to do real well at about 75%. But if they have obviously if they have T1 and repeat T2, they need a cystectomy. Or if they have T1 and on repeat have T1, they have a less than 20% chance that BCG is going to work. Doesn't mean you can't do it, but they need to go in eyes wide open that they're probably going to lose their bladder. Intravesical therapy, so this was a recommendation of perioperative, which Dr. Gonzalo talked about. I'll jump ahead to a conversation we had yesterday. We agree upon gemcitabine, again, easily available, less expensive, a little bit less toxic. Low risk, don't need induction. Intermediate risk, this says either chemotherapy or BCG immunotherapy. I talked a little bit about if I have the low grade in that intermediate, I will tend to use chemotherapy and kind of save BCG in a sense. save it from the standpoint of the patient needing it, or even like my stock of BCG, and then high risk should get BCG. So this is a cartoon of the proposed mechanisms of BCG. So whenever I have a cartoon that's going to show you how things work, it just kind of tells you we really have no idea, right? Because we're coming up with cartoons. Maybe this is a little better cartoon analyzing cell-mediated immune response. You see here sort of the innate immunity and adaptive immunity, and now we're understanding the role of PD-1 and PD-L1. There's no suggestion that one strain of BCG is better than the other. Even the strength of BCG, and Mark talked eloquently about that, using a third or a half a dose, and even the duration of maintenance. And I'll show you this a little bit. So this is a Queto study group. Third of a dose, this is 5-year follow-up versus full dose, no difference in recurrence, no difference in progression. ERTC study, so they went third dose, full dose, 1 year, 3 years maintenance. So the combination of all of those, bottom line here, you can see all 4 lines, no difference. So these are, again, include third dose 1 year maintenance versus full dose 3 year. Remember that full dose 3 year trial, only 17% of the patients made it out to that because they couldn't tolerate it. So the conclusion's no difference. I think we have to think about who's going to benefit from that, who's not from going out that far. Again, you should consider maintenance for a year in intermediate risk, for 3 years in high risk. I think defining BCG response, we touched on it, 6-month mark is critical. T1 disease, if you have persistence after even 1 course, that's BCG refractive. They don't need 2 courses. The CIS TA high grade, failure is failing 2 courses or a course and majority of the maintenance. Or if you're progressing to T1, a TA going to T1. BCG relapse in intermediate or high risk, you should evaluate the upper tracts. If after a single course, you should give them a second course. That's all that says. If they have recurrent T1, so on the follow-up after, if they're T1, you should consider them for cystectomy. If they're TA and they failed, or CIS failed 2 courses, you shouldn't give them a third. You should, if after those 2, consider them for cystectomy. If they don't want a cystectomy, again, talk about things like trials or other therapies if you don't have the trials available, like we often do. If they're fit, take them to cystectomy. If not, what do you do here? I'll just make the point that all of the studies, they all do this, right? Like I mentioned the other day, they look great early on and they dive off. So 40% at 1 year, this is docetaxel. This is what we talk about, that combination, which is effective and maybe the most effective. Look at these numbers. But it's a big deal in the office. It's a lot of hours in the office. I'll talk a little bit about, T cells can identify cancer cells, through the, they block T cells by the program death ligand. That's what PD-1 or PD-L1 is. So they by expressing that, normal cells or cancer cells express it in high degrees. They basically leave us alone. And that's what some cancer cells can do very often and be kind of, in a sense, immune from the attack of the T cells. So I think I mentioned this yesterday. Their immune checkpoint inhibitors are making their way in the non-muscle invasive space. Interestingly, for lung cancer, if you do PD-L1 staining, you can predict who's going to respond or not. That doesn't seem to work, interestingly, in bladder cancer. A number of trials, mainly in advanced cancer or invasive cancer, non-muscle invasive. This is sort of a trial that gained FDA approval and then got some traction. It's called the Keynote trial of non-muscle invasive bladder cancer. And these are patients that single arm and were treated with pembrolizumab for 200 milligrams for every 3 weeks. And you could see here that the numbers, again, it's the same type of curve, right? Kind of going down a year, everyone looks pretty good, but it plateaus out. Of the patients, the numbers again dive down to about sub 30% here in the long term. 1 year, and the treatment went out to 1 year for these patients if they responded. A 1 year treatment of 200 milligrams of Pembro every 3 weeks is $320,000 in a year. So you just have to be wary of some of these things versus docetaxel and so forth. Finishing up, you have to be aware of the toxicities, which can be lethal and significant. Don't forget the role of cystectomy. Patients, if you delay cystectomy, here's another graph of that shows if you delay cystectomy, some people say, well, I'll wait till I get invasive. You've lost window of opportunity. Their curves, their survival is worse. So don't forget the role. There's not a role in low risk except if you've exhausted all options. If you're fit with this or variants, you should do it. And in patients who have failed 2 induction courses. Quick comment about follow-up. At 3 months, you should do a cysto. This is one of the most important. I'll show you a graph here about how we do follow-up. I will just make a plug to say, you know, you can survey these patients. You can do in-office fulguration. How many people do that? If you have a patient, do you use laser or Bug-B? Bug-B. Yeah, I mean, it's very effective. Does anybody just, 80-year-old patient, they keep coming back low grade, just leave it alone? Yeah. I mean, I think that's a very reasonable thing to do. I think there's more risk in them going to the OR. Very well tolerated. So follow-up here is, I'm getting the hook a little bit. You can see here, so that intermediate low grade about every 6 months, the intermediate high grade and high risk every 3 months for that. I'm going to show you a little bit of a study we did where we compared.
Great presentation. Thank you very much.